Good afternoon, ladies and gentlemen. We continue our ophthalmological lectures. Today is a very important and interesting topic, diseases of the lens. Before we start to speak about the diseases of the lens, I would like we remember the anatomical structure of the lens and its function. I hope you remember that the lens is transparent, biconvex, crystalline avascular structure placed between iris and the vitreous body. So here is the lens, yeah. Accommodative power of the lens near 20 dioptries. I hope you remember this is the second refractive powerful structure. The first is cornea. Its refractive power is 40, no, near the 40. So the accommodative power of the lens near 20 dioptries. The thickness of the lens near 4 to 5 millimeters. A lens consists of proteins and water. On this picture, you can see the position of the lens in the eye. So, lens is situated in posterior chamber. Its contact with the iris anteriorly, and here is anterior chamber. Here is the pupil, and lens contact mm, with the vitreous body posteriorly. Anatomical structure of the lens: anterior capsule, single layer of cuboidal cells, lens fibers, nucleus and cortex, and posterior capsule. All the structures, knowing of all the structure is very important of the lens surgery. We will speak about this surgery a bit later. Now we should speak about anomalies of the lens. We can divide all anomalies on cataracts, displacement of the lens, and congenital anomalies of the lens. Today, of course, we couldn't speak about all diseases of the lens, but we should pay attention on more important. As for the congenital anomalies, you could see lenticonus, lens coloboma, micro and spherophakia, biphakia, aphakia, remains of the fetal hyaloid vascular system, and remains of hyaloid membrane. Any opacities of the lens we call cataract. On this picture, you see normal, transparent lens. On this picture, you see the cataract, so opaque lens. Of course, you know that light goes through the cornea and lens to the retina, and if the lens is not transparent, of course, this situation is affect visual function. Cataract is rather often situation, and you can see cataract in many patient, in many people. That's why we should speak about classification of the cataracts, about treatment of the cataracts. And at the end of the lecture, I think we will have opportunity to see, to watch the short movie. Okay, so anatomic localization, according to like anatomic localization, we can divide all cataracts on anterior polar, posterior polar, spindle-shaped, lamellar cataract, nuclear cataract, cortical, posterior subcapsular cataract, and total cataract when opacities uh, are affected all lens. According etiology, we can divide cataracts on senile or age-related. To tell the truth, um, this is more often cataract. Many people after 60 have cataract. Congenital cataract, traumatic cataract, associated with intraocular diseases like uveitis, glaucoma, different retinal degeneration, and other diseases. Cataract may be associated with systemic diseases like metabolic diseases, for example, diabetic mellitus, renal diseases, skin disease, connective tissue disorders, central nervous system diseases. And cataract may be caused by different pathological agents like radiation, X-ray, for example, microwaves. Uh, Cataract may be caused by um, different medicines like steroids, for example, different myotics, eye drops, and other some other medicines. Clinical features of the cataract rather simple. So the patient mm, can usually complains on bad vision. In some cases, he can complains on glare, colored halos, black spot in front of the eye. The patient can say that image become blur and in in last stages the patient can say you that he has loss of vision. Look on this picture. In this picture you see how the normal eye can see. Here you see how the patient with cataract can see the same picture. Signs. Mm, When we suggest the cataract, or we should check visual acuity, of course, in patient with cataract visual acuity decrease, of course. Test, we can make test of iris shadow, oblique illumination examination, uh, direct ophthalmoscopic examination, and of course slit lamp examination uh, or examination with biomicroscope can help us to make correct diagnostic. On this picture you can see how what can we see uh, using the slit lamp. Look, we look in a slit lamp in biomicroscope during your practical classes. You can see this device. Some of you um, have already started ophthalmological classes, so you can see cornea, uh, then transparent anterior chamber, and this is lens. You can see all structures of the lens, and if there are any opacities, you can see these opacities without difficulties. Okay, congenital cataract occur in a variety of morphologic configuration, including polar, nuclear, lamellar, diffuse, polymorphic, anterior, and posterior cataract. So, according the location, congenital cataract may be in very great differences. Look on this picture. This is the nuclear cataract, nuclear congenital cataract. Here we see this cataract by slit lamp. This is like a chart how this nuclear cataract can see. These are pictures with the examples of congenital cataract. Look, this is a nuclear cataract. This, I think, also nuclear cataract. This is small mm, dot. I think this is polar cataract. Here, you can see here not just the cataract but also iris anomaly. Congenital cataract also not just mm, single disease, but in some cases this is just one signs of different syndrome. For example, I hope you know Marfan syndrome, and in this syndrome, uh, the patient um, has skeletal uh, anomalies, cardiovascular anomalies, and ocular anomalies. For this Marfan syndrome, very mm, very often we can see ectopia lens, increase corneal diameter, and increase the size of the eye. We can see flattened iris surface, and we see the small myotic pupil, high myopia, maybe glaucoma, megalocornea, and nystagmus, and of course opacity of the lens, but also not just opacity, but dislocation of the lens. So when you see, I mm, I would like to you don't forget that if you see congenital cataract, don't you should think about different syndromes. Again, syndrome, well, Marchesani syndrome, and in which also patient can have cataract, but also this syndrome is characterized by brachymorphic mm, with short suture and stubby hands with stiff joints. And for this syndrome, microphakia and spherophakia are rather often. Also, myopia, cataracts microcornea, megalocornea, and angle abnormalities have been reported. Reyes syndrome also have cataract. In this syndrome, patients also have cataract and also have usually have changes in iris. Uh, Greg syndrome or congenital rubella syndrome. In this syndrome, cataract may be associated with retinitis pigmentosa, microphthalmia, mesodermal dyskinesis, glaucoma, squint, and other pathology of the eye. For these syndromes, pathology of the ear and heart is rather often. Okay, so again, I would like um, to say you that if you see the congenital cataract, you should examine this child very carefully. You should send this child to other specialists um, to exclude the general pathology and to exclude the syndrome and other problem. Okay, let's go further. We will speak about senile or age-related cataract, and this cataract, um, to add anatomical classification, can be classified according to maturity. We can divide all cataract on incipient cataract, immature cataract, mature cataract, and hypermature cataract. This classification is rather important for surgeon who is going to make cataract surgery. Okay, on this picture, you can see examples of the cataract. Look on this picture, it's a mature cataract, so all structures of the lens are opaque, and when you examine the patient, you see just a gray pupil. On this picture, you can see hypermature cataract, slight lens dislocation. Oh, on this picture, you can see the difference between immature, and mature cataract, but I think it's not so important for you. You just have to know that um, this classification is exist. I would like to say more pictures. On this picture, you can see different types of the cataract. It's immature. These are examples of mature cataract. So, of course, you can see that in these, if the patient has such cataract, he can't see nothing and he has very bad visual acuity. To tell the truth, nowadays, thanks goodness, we rare see such cataract, but in some cases, uh, when the patient come too late to ophthalmologist, we can see such cataract. To tell the truth, nowadays we try to operate the cataract early when the lens is still transparent, no, not full transparent, but not totally opaque. And in cases, it's easy to operate, but when we see so opaque lens, it lens is hard and usually difficult to operate such cataract, but we will discuss this further. Okay, again examples, different cataracts. Okay, We have already mentioned that one of the cause of the mm, cataract formation is diabetic mellitus, and in some cases, the patient can have diabetic cataract. And I hope you know that a lot of uh, people in old age have diabetic mellitus. But when they have cataract, we don't have that this is diabetic, true diabetic cataract. It's just a cat or age-related cataract or senile cataract in a patient with diabetic mellitus. But true diabetic cataract usually mm, uh, is appear in a young patient with a type 1 diabetic mellitus or with mm, severe general problems. The most common ocular manifestation of diabetes are bilateral cataract, retinopathy, lesion of optic disc. It's characterized for types 1 diabetic mellitus. A special time of diabetic cataract is a special type of cortical cataract has been seen in many diabetic patients with type 1 diabetic mellitus. Usually is bilateral process. Tetanic cataract, this is condition is usually the result of accident removal of the parathyroid glands during uh, thyroidectomy. Also, it may be idiopathic. The lens develops multiple small, white or multicolored punctate opacities usually located in the subcapsular region. Cataract caused by rheumatoid arthritis. Uh, it's rather rare, but and usually this cataract we can see in a patient with iridocyclitis or uveitis. And then such patients with rheumatoid arthritis also have cataract. Treatment of cataract. Today I have already mentioned some methods of treatment, but if we know the cause of the cataract formation, we should treat the cause. For example, if it's a true diabetic cataract, we should treat this diabetic mellitus to prescribe normally insulin therapy and correct um, other structures such as lipid levels and other metabolic disorders. But in a case of age-related of senile cataract, we know the cause, but we can't to treat this cause. Sometimes in initial cataract, for example, we can prescribe different drops to which delay progression of the cataract. There are some eye drops like Oftantachrome, Quinax, and so on. But to tell the truth, mm, we can't say that these drops are really effective. If they would be effective, we don't have so many cataract surgeries. That's why mm, the most important way of the cataract treatment, of course, surgical treatment, surgical management. Mm, I would like to say you some maybe historical methods, but you should know about them. Intracapsular cataract extraction, when we remove whole lens with the mm, anterior and posterior capsule and nuclear and cortex. Extracapsular capsular extraction, when we make a hole in anterior capsule of the lens, remove nuclear and cortex, and then implant intraocular lens in this capsular sac. And after this operation, patient have rather good visual acuity. Phacoemulsification is the example of extracapsular extraction when the also small incision we make in anterior capsule of the lens, but um, lens nuclear and cortical of the lens extract by uh, special phaco machine with the ultrasound, vacuum aspiration and irrigation. Now again, pictures for you, traumatic cataract, you can see. And on this picture, I would like to describe you how we make extracapsular cataract extraction. So, small incision, yeah, of the cornea with a special needle, we make hole in arterial capsule of the lens. Then we remove lens, then wash uh, sac, lens sac, and then implant special intraocular lens. On this picture, you see the same method, but using the fake machine. After removing the lens, it's necessary to implant into eye intraocular lens. It's important because mm, if we don't put inside intraocular lens, the patient uh, will have to wear very big glasses near plus 13, and you can imagine how it's inconvenient. So we calculate intraocular lens using the indexes of the cornea, the size of the eye, and we calculate the refractive power of the intraocular lens. When we remove part of the anterior capsule, co- cortex and nucleus of the lens, we save the posterior capsule of the lens. But the posterior capsule of the lens also may become opaque. And in this case, if the posterior capsule become opaque, we make YAG laser posterior capsulotomy. It's an outpatient device just using the laser explosion. On this picture, you can see the correction of aphakia. So aphakia, it's a condition without the lens. You can see the correction by soft contact lens, by hard contact lens and with the glasses. And now I will try to show you, sorry, I will try to show you the video, okay, the video of the cataract surgery. This video was made in our clinic in Oka Center just some days ago. I have already mentioned that cataract surgery is a routine operation, and every day in our clinic, for example, we made six, eight cataract surgeries. And this is the example of the surgery of mature cataract. You have already seen that cataract was totally opaque. Lens was totally opaque, so it's mature cataract. And a doctor made, made two paracenteses, and then uh, he he add in anterior chamber special solution to color anterior capsule of the eye of the lens to make it visible. Then it washed the eye. This is a viscoelastic. It's a special solution which help us mm, to save cells of endothelium during the operation. And look, now the surgeon makes the hole in anterior capsule of the lens. We call this hole capsular rhexis. You can see on this surgery that before surgery we should dilate the pupil to make the lens is good visible. It's important for cataract surgery to make mydriasis. For mydriasis, we use a special mydriatic drop, like tropicamide, for example, 1% tropicamide. Okay, the doctor very carefully using the forceps, special forceps, try to make uh, the whole in anterior capsule. To tell the truth, it's not so easy because of the um, very mature cataract. It's easy to work in a cataract immature, but I would like you um, to show not just ordinary case. This case rather complicated, and mm, you can see you can have opportunity to see as a very interesting case. So the surgeon add viscoelastic and try to continue surgery. I would like to say that uh, microscope with the camera give us opportunity to watch operation after surgery, to show these operations for you. Okay, and surgeon make um, additional incision and cut the anterior capsule. Okay. Very interesting cases. The capsular axis should have a very very round shape, and it's important for future phacoemulsification of the cataract. Okay, well done. You can see here is the capsular eggs, and the surgeon removed the anterior capsule um, of the lens. So now the surgeon move the nucleus of the lens, add again viscoelastic, and pay attention. This is a special device which helps us using ultrasound to remove these lens. The surgeon wait, and now you can see how the surgeon will start to make phacoemulsification. Using ultrasound and vacuum, he should cut the lens and then to remove these lens pieces. Okay, you can see. To cut and eat the pieces of the nuclei of the lens. Believe me, that it's not easy to make it in this hard nuclei. But our surgeons in our clinic are very experienced. Mm, to tell the truth, personally, me, I don't make cataract surgery. I'm excimer laser surgeon, but in our clinic, the cataract surgery is made mm, by the head of the clinic, Rasin Oleg Grigorievich, and he is also a teacher, a lecturer from Ophthalmology department. So the students who will be study in who will be have your practical classes in our clinic will have opportunity to see such operation in a mm, real time. So the nucleus of the lens has already removed. You can see now the red reflex from the fundus of the eye. Um, so when we see the red reflex, it's easy to operate. And now the surgeon using the aspiration and irrigation will remove the cortex of the lens. Piece by piece, step by step. The main advantages of the phacoemulsification is a small incision, and after such operation, the patient can go home without any inconvenience. So these small incisions make cataract surgery mm, is ambulance surgery. Mhm. Okay, the surgeon tried to remove all pieces of the cortex, or if we leave mm, some cortex in eye, uh, these pieces of the cortex uh, will be opaque, and we should go to the operation theater again and remove these pieces. So it's very important to wash everything very carefully. Okay, a little bit more. So the surgeon has already removed the nuclear cortex of the eye of the lens, and now it's time to implant the new artificial intraocular lens. The incision is small, but lens is rather big, so we use the soft lens. Look, this soft lens the surgeon put in a cartridge and will implant this lens. Mhm. Fold the lens and implant. Now you will see the process of intraocular lens implantation. Mhm. Okay, look, 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 look. Very small incision, and you see the lens is rather big, and the purpose to put all part of the intraocular lens in posterior chamber in capsule sac. The surgeon work very carefully. When you look at this video, it seems to that it's so easy to operate, but believe me, it's really, really very difficult. It's microsurgery, and it's really very difficult to understand how to work by microscope, and it's very important. Maybe somebody mm, in your groups um, would like to have would like to study ophthalmology, would like to be ophthalmologist, and I think this is a very good idea, and this is a very good part of the medicine. Very interesting discipline and very interesting surgery. Okay, the surgeon implants the intraocular lens, and I think he's going to finish his work. Yeah, he closed uh, incisions by a physiological solution, saline solution, and you see 15 minutes, and patient will have absolutely new vision. Surgeon check intraocular pressure and closed the last incision. No, uh, usually we don't pay sutures, but in some cases we can add small suture. Okay, the doctor decided to make a small suture for incision because the case was not so easy, and it's better to close the wound carefully, and he decided to put just a just a small suture. You can see the suture is very small, and you can see how the ophthalmosurgeon use instrument to make suture. Mhm. Okay. Mhm. At the end of the operation, the surgeon usually make intraocular subconjunctival injection of antibiotic and corticosteroid. Okay, I think this is all. Very good results, and I would like you to say thank you very much for your attention. I hope you you liked the cataract surgery, and maybe somebody would like to be ophthalmic surgeon. You're always welcome. See you in our practical classes, and goodbye.